بسم الله الرحمن الرحيم نحمده ونصلي على رسوله الكريم أما بعد السلام عليكم ورحمة الله وبركاته. All praise belongs to Allah subhanahu wa ta'ala, who through an infinite mercy and wisdom has made us human beings. Peace and salutation upon the noble master Rasulullah sallallahu alayhi wasallam. Respected audience, it is well known that Allah subhanahu wa ta'ala has created human beings as very complex people. In the Quran, Allah subhanahu wa ta'ala says, وَفِي أَنفُسِكُمْ أَفَلَا تُبْصِرُونَ, that will people not look within themselves, they will see the greatness and the signs of Allah subhanahu wa ta'ala. Are we people not looking at the greatness of Allah subhanahu wa ta'ala? So this particular body that Allah has given us is a trust as an amana. And if a person has good health and looks after it, then that person will be able to worship Allah subhanahu wa ta'ala like how he ought to be worshipped. Similarly, when a person goes through some challenges in life without understanding the challenges, the changes, and all of those things, then it becomes difficult to worship Allah subhanahu wa ta'ala when the health is not there. We are here this evening, it's not a very lengthy program. The program will go as follows, inshallah. The talk time that Dr. Saab will be doing will be approximately 45 minutes, give and take a few. And then we have left at least 45 minutes for questions. Whatever there is, there will be questions, etc., that will be there. We're just going to request all those that are here to kindly mute yourself. Make sure that you are mute. If there are any questions within the program, one is able to post it on the chat. Once that is done, at the end of the chat, inshallah, I will try and read them out to Dr. Saab, and thereafter, inshallah, he will discuss it in the meeting that we are online. More important than what he's going to do is the discussion that will take place post this. So if you have any discussions or any questions, try and keep it so that at the ending, if it hasn't been answered, then you will be able to ask it once Dr. Saab has finished his presentation. Dr. Muhammad Karodia, he's originally from Yasfam, staying in Baklu at the moment. He is a clinical hematologist and he practices at the George Mukhari Academic Hospital as well as the Safakho Makhato Health University. We will hand it over to him, inshallah. He will present, and thereafter we will take the questions at the ending. If there is anything, you could post it on the chat, and I will try and follow up from there, inshallah. فليتفضل مشكورا Dr. Saab.
Assalamu alaikum wa rahmatullahi wa barakatuh. Maulana, am I audible?
You audible, alhamdulillah.
Jazakallah. First of all, Maulana, Jazakallah for the kind invitation and the wonderful introduction. As Maulana said, my name is Muhammad Karoja. I'm a clinical hematologist at George Mukhari Hospital in SMU. And so we're going to have a brief introduction today of the blood disorders, and as the slide says there, from anemia to life-threatening blood cancers. Well, before I begin, just a small disclaimer. I am by no means an expert on anything, let alone blood disorders. But inshallah, we make dua that this presentation is of benefit to all. Bismillah ar-Rahman ar-Rahim. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي يا رب صل وسلم دائما أبدا على حبيبك خير الخلق كلهم. So this is an overview of the discussion this evening. We will begin by looking at the hematopoiesis, which is the production of blood, and then look at a few of the common disorders. So the anemias, then we'll move over to the hematological malignancies, the leukemias, the lymphomas, and then a little bit of multiple myeloma. And then we have some time further, we'll do some of the miscellaneous blood disorders. And we'll have some time, hopefully in the end, to have a discussion. So this first slide essentially is where it all begins. This is the process of hematopoiesis or hemopoiesis. This is the formation of blood, which, as you can see here, begins in the bone marrow. So the bone marrow produces the different types of blood or the blood cells. Three most important ones are the platelets that you see here, and of course the different types of white cells, essentially mainly the neutrophils and these lymphocytes that you see at this side here. So all of these cells have different functions, of course important functions, and beginning with the red cells, or the erythrocytes, they produce, or rather produced by this master cell. So this master cell is the hematopoietic stem cell. And this is a cell, as you can see, that leads, of course, to the production of all of these cells. So let's begin with these red cells. Essentially, the function of the red cells is to carry oxygen to the rest of the body. And you'll see a little bit later when there's a reduction in the red cells, of course, that's called anemia. And that will lead to the clinical presentation that we'll talk about. And then, of course, the platelets, and the platelets together with the coagulation system are responsible for clotting. So, of course, if you get cut, you see that scab that is formed there, and that scab essentially is made up of platelets and some coagulation factors. And then last but not least, these white cells. The two main white cells, of course, are the neutrophils, and neutrophils are responsible for prevention and defense of bacterial infections. And the lymphocytes that you see here are responsible for fighting viral infections. So we start off talking about anemia. So anemia essentially is a condition in which your body doesn't have enough red blood cells, and this then affects the oxygen carrying capacity of the body of the red blood cells. So this leads then to the clinical phenotype or the clinical presentation, where the patient presents with tiredness, fatigue, dizziness, pale skin, and in fact, even all the way up to heart failure. So the most common cause of anemia is iron deficiency anemia. In fact, the prevalence worldwide is over 200 million people. It's certainly the most commonest cause of anemia in our country as well. The most important thing about iron deficiency anemia is really the cause. And by far, the vast majority of patients who present with iron deficiency anemia is actually caused by blood loss. Poor appetite is an uncommon cause, and in fact, the appetite has to be extremely poor for one to develop an iron deficiency anemia. There are patients who have absorption problems, particularly those who have gastric surgery, gastric bypass surgery. Those patients may present also with iron deficiency anemia. And as we said earlier, the symptoms of anemia essentially is tiredness. Patients feel dizzy, feel weak. They may even present with shortness of breath. They may present with difficulty of the shortness of breath, even with minor activities, depending on the degree of the anemia. This is common. We see it essentially in women, children, and elderly as well, more often than others, but can be found, in any patient. We need to distinguish the pathological iron deficiency from the physiological iron deficiency. What I mean is that iron deficiency is extremely common in children and adolescents. This is physiological, where the absorption or the intake is not enough to produce hemopoiesis, and hence they have an iron deficiency. But the pathological one is the one that we're interested in, which is more important, and this needs to be diagnosed correctly. So how do we diagnose iron deficiency anemia? First of all, the patient will present with these symptoms that we talked about: the tiredness, the weakness, the fatigue, the pallor or the paleness of the skin, and then we do a full blood count. The full blood count essentially will show that the HB or the hemoglobin is low, and this is accompanied by small red blood cells, and we call this a microcytic anemia. Now, this needs to be distinguished, and we'll talk a little bit later, because often it's confused with thalassemia, and thalassemia, of course, is common in our community, but we'll talk briefly about thalassemia a little bit later. So we need to do this full blood count, and on the full blood count, as I say, the anemia will be there, and then follow that up with the iron profile. So the iron profile shows that the iron stores are low, most importantly, and that's measured by what we call the ferritin blood results. You see the ferritin is low, and that will confirm the diagnosis of iron deficiency anemia. So treatment. In women, most often, the cause is excessive menstruation, and sometimes we need to refer patients to the gynecologist to find the cause of the excessive menstruation. And often in males, the cause will be gastrointestinal bleeding, so bleeding in the stomach and the rest of the gastrointestinal tract. So patients who have ulcers, perhaps, those who have gastritis, or even those with large bowel disease like colitis, or patients can present mainly if it is upper GI bleeding. In other words, if the bleeding is from the stomach or higher up in the bowel, then this will present with something called melena, which is dark stool. So one needs to keep a lookout for dark stools. So that's the first part of the treatment, to find the cause and to treat the cause. Then the next part, which is really the easiest part, is really to replace the iron. And one can do this in a few different ways. The first one is to give oral iron, and there's many different preparations out, the original ferrous sulfate, and then there's FerriMed, which some of you may be familiar with. And then, of course, there is the more later ones, the fancier ones, so to speak, like Califer, and my personal favorite, Sideral Forte, which also works very well. But we can also give intravenous iron, and so this is iron in the drip. And there are certain pros and cons to using one over the other. So the benefit of using intravenous iron is that, of course, one doesn't need to take iron for a lengthy period, because when one is diagnosed with iron deficiency, you need to take the iron supplement until the hemoglobin has normalized, and a further 6 months to replace the stores, so the stores can be replete. With intravenous iron, of course, the stores are given once, and depending on which preparation you use, there's 2 or 3 or 4 different preparations. But if you give a total body dose of iron, then that can be replaced once off, and one doesn't need to take, of course, the oral iron. The other problem with oral iron, of course, is that it's sometimes not tolerated very well for patients. It gives you gastrointestinal symptoms. Some patients may have nausea and vomiting, and may even have constipation, and some patients may even have diarrhea. So there are side effects associated, and that's one benefit of using the IV iron. The problem with using IV iron is that firstly, it's expensive. But secondly, there's a small proportion of patients who may have allergic or even more severe anaphylactic reactions. So your doctor needs to decide carefully on the form of the treatment, which is more appropriate for you, and then take it forward from there. The second cause of anemia, which is fairly common, is something called megaloblastic anemia, and is most often due to a deficiency in vitamin B12, and sometimes, of course, in folate deficiencies. Again, like the iron deficiency anemia and all anemias, patients will present with this tiredness, with the shortness of breath. But in the vitamin B12 deficiency and the folate deficiency, they may even present with mouth sores and also some nerve issues or neural issues, neurological issues. This can be from things like peripheral neuropathy, where you have numbness of the peripheries, your hands or your toes, and even cognitive effects can also be seen in patients with the megaloblastic anemias. There are different causes again for this, but pernicious anemia by and large is the most common cause of vitamin B12 deficiency. Contrary to popular opinion, it is not diet that is more common. It is pernicious anemia. And pernicious anemia is an autoimmune disease in which your body makes antibodies against the intrinsic factor, and this intrinsic factor is produced in the stomach. And the body needs this intrinsic factor to absorb vitamin B12 because it binds to the vitamin B12 and it's then absorbed. So when there's an autoimmune attack on the parietal cells of the stomach, there is a deficiency then in this intrinsic factor, and hence one doesn't absorb the vitamin B12 well, and that leads to the vitamin B12 deficiency. Just a small word on diet. Yes, vegetarians or people who don't eat meat or foods rich in vitamin B12 may present with a megaloblastic anemia, but this takes many years actually. So you have to be a poor eater or not eat meat for 5 to 7 years, they say, to become truly vitamin B12 deficient. There are some malabsorption syndromes and some medications that can cause vitamin B12 deficiency as well, but these are not very common. Again, how do we make the diagnosis? Again, it is the correct patient, in other words, the patient who presents with these clinical symptoms, and then one does the full blood count, and again, we see an anemia. But what is different here to the iron deficiency is that instead of the cells being small or microcytic anemia, here the cells are large, and we call this a macrocytic anemia. And then one follows that up by doing the vitamin B12 levels and the folate levels, and then the diagnosis is made. The treatment again is to find the cause. So if this is a malabsorption syndrome, or if it's poor diet or it's medication, then of course those things can be changed. But by and large, most patients will receive vitamin B12. The supplementation in the case of pernicious anemia will have to be through an injection, so through the parenteral route. And depending on how severe the anemia is, one will need injections. Initially, 1 injection a week, and for the first week, and then monthly for the first month, and then weekly for the first month. So daily for the first week, I apologize, daily for the first week, weekly for the first month, and then monthly for 6 months. And then if it's pernicious anemia, as I say, that will need to be given periodically, perhaps every 3 months. In the malabsorption syndrome as well, one will need lifelong vitamin B12 treatment. So it's fairly easy disease to treat. Okay, so let's move on now to the blood cancers or the hematological malignancies. And the first one that we're going to talk about is the leukemias. And leukemia actually comes from the Greek word, two Greek words, which means, which refers to the production of the white blood cells. So essentially, it is a cancer of the blood-forming tissues of the bone marrow, in which the bone marrow makes or produces these abnormal white cells. And these white cells are malignant cells or leukemic cells. And what these leukemic cells do, they displace normal blood production from the cells, from the bone marrow. Hence, the bone marrow doesn't produce normal cells. It's almost like in your garden, if weeds start growing and you allow that to grow, essentially you don't have normal grass because these weeds have taken over, and these malignant cells are almost parasitic. They have a survival advantage over normal cells, and they're able to crowd out normal cells, and hence patients then present with what we call cytopenias. That is the reduction in the hemoglobin, so they present with a severe anemia often, and they also present with a low platelet count, and that's called a thrombocytopenia. So they have low platelets, they have low red cells. So that's why the patients present with tiredness, weakness, fatigue, shortness of breath as a result of this anemia. And as a result of the thrombocytopenia or the low platelet count, they then present with bleeding. And often this bleeding can be severe. Sometimes it starts off mild with bleeding underneath the skin or subcutaneous bleeding, these little pinpoint hemorrhage, what we call petechia, and that can then worsen to purpura and ecchymosis, which are large bruises. And then we often see patients presenting with mucocutaneous bleeding. So this is from the mouth, the nose, and sometimes even from the gastrointestinal tract. So they may have bloody stools, or even melena stools. But what they also present with is these abnormal white cells. So the white cell count goes quite high, but these are not normal cells. These are these malignant cells. And these malignant cells essentially, by crowding out the bone marrow, has caused the white cells are then abnormal. And as a result of abnormal white cells, patients get infections, and they can get severe infections because they present with a neutropenia, with neutrophil counts are low, and these infections are often life-threatening. So how do we diagnose leukemia? Or perhaps before we even get to that, let's talk about the different types of leukemias. So we have the acute leukemias and the chronic leukemias, and the terms acute and chronic don't refer to necessarily to the severity, but they refer to how progressive, how fast these diseases progress. So the acute leukemias are the more life-threatening ones. They develop extremely rapidly. Often patients would be well 1 month ago or 2 weeks ago, and this presents very acutely, and they present with these cytopenias that we talked about. So all these symptoms of having low blood counts. There are two main types of acute leukemias, the acute myeloid leukemia, as you see here, the AML, and then the ALL, which is the acute lymphoblastic leukemias. Acute myeloid leukemias are more common in older patients. So as you get older, the risk of AML increases. And ALL is essentially more often a disease of childhood. So as you get older, the ALL reduces. In fact, the most common age group for patients with ALL is the 2 to 10 age group, so from 2 years old to 10 years old. So these are the acute leukemias. We then get the chronic leukemias, and there you have CML, which is chronic myeloid leukemia, or chronic lymphocytic leukemia, which is CLL. And again, the M and the L, the myeloid and the lymphoid in both acute and chronic, actually refers to the cell of origin. You'll remember I showed you the slide initially of hematopoiesis, and we said there's two different types of white cells. I referred to the lymphocytes and the neutrophils. So the myeloid leukemias is essentially a disease of the neutrophil cell line, and the lymphoid leukemias is a disease of the lymphocyte cell line. So CML is chronic myeloid leukemia, and CLL is chronic lymphocytic leukemia. These often have a more insidious course. In other words, it takes longer for to develop and longer for patients to present with symptoms. CML is a disease that's found in younger patients and older patients. In fact, it is one of the first, certainly the first hematological malignancy that in which there was a genetic abnormality was found. So in the 1970s, early 1970s, 1972, they found the genetic basis for this, and this is called the Philadelphia chromosome. And what happens is that this Philadelphia chromosome causes an abnormality in the bone marrow, so it produces too many of these white cells, and it produces these malignant white cells that leads to essentially a very high white cell count. The hemoglobin and the platelets are not necessarily low like how you see in the acute leukemias, but the other pertinent finding in patients with CML is they often have a very large spleen. So they have a massive splenomegaly, and this is one of the telltale signs. The chronic lymphocytic leukemia, on the other hand, is a disease mainly of older people. In fact, the average age of presentation of CLL is 72. And in the Western world, CLL is actually the most common hematological malignancy. So as the name suggests, it is a chronic blood malignancy of the lymphoid organs or the lymphocytes. And so in the blood, there is this increase in lymphocytes, and patients often present with enlarged lymph nodes. They present with these large lymph nodes throughout, generalized lymphadenopathy, so it can be on the neck, in the axilla, in other words, in the armpit, and also in the inguinal areas. And they may also present with a large spleen. And as I said, this is quite common in the older groups. So how do we diagnose these leukemias? Again, it's patients who present with these particular symptoms that we talked about, and those symptoms associated with the low blood counts, or the patients may have splenomegaly, or the patients may have splenomegaly, in other words, a large spleen, or even enlarged lymph nodes. And sometimes they may present with B symptoms, which is what we'll talk about a bit later in the lymphomas. But essentially, these are night sweats, weight loss, and fevers. So they can present with any of these symptoms, and then we go and do a full blood count. In the full blood count, we can see that they may or may not be an anemia and a low platelet count, but a high white cell count. And then when we look at that white cell count under a microscope, we can see what those cells look like, what is the origin of these cells. And to confirm this, we then go and do a bone marrow test. And the bone marrow test must not be confused with a lumbar puncture. This is done from the bone. Mainly, we use the hip bone from the back posteriorly, and we draw a sample of blood together with a trephine biopsy, which is a piece of the bone, and we subject it to a few tests. One is under the microscope. We look at it, and we call it the morphology, and we can see the individual cell lines and see if there's increased or reduced cell lines. And then we do a sophisticated test called the flow cytometry. So flow cytometry is a more recent test, and in medical terms, recent is in the last 20, 25 years, where we can subject this test into an analyzer, and it looks at the individual proteins that are expressed on these cells, and this is called the phenotype. And by virtue of these proteins, we can tell what the cell is. In addition to that, very importantly, and more recently, it has become even more important, is to do the genetic testing, because the genetic testing helps us with the diagnosis, number one. Number two, it certainly helps us with the prognosis. Certain genetic abnormalities confer a better prognosis, and certain ones confer a worse prognosis. So the genetics helps us as well with prognosis, but absolutely the genetic helps us with treatment as well. For example, one of the acute myeloid leukemias is called the acute promyelocytic leukemia, or the AML-M3. And in this particular leukemia, they have a genetic abnormality known as translocation 1517. I hope you're not taking notes. I'm just trying to sound clever. You don't need to know these things, just for your information. So this translocation 1517 is associated with a good prognosis because we have an excellent treatment that is directed at this translocation, which is called a directed treatment. This is targeted therapy. And hence this leukemia, from being one of the worst prognosis, is actually now a leukemia of the best prognosis. So we do this on the bone marrow, we do the genetic testing. Now, having said all of that, how do we treat patients with acute leukemia? And you'll see there I've said supportive therapy, because most importantly, when patients present with leukemia, of course, they have these cytopenias, as I said, they're bleeding, they have the anemia, and they're very tired. And of course, they may have infections. So we support them by giving blood transfusions, both of red blood cells and platelets as well, and also treating infections very aggressively, because remember, their white cell counts are low, hence the soldiers, their defense mechanism is low, and they are susceptible to infections and are not able to fight these infections off. Hence, the treatment has to be fairly aggressive. So we give strong antibiotics in the drip to get over this infection. And then thereafter, once we have stabilized the patients, we go on to the specific therapy. And the specific therapies will vary from the different types of leukemias. The acute leukemias mainly will get high dose multi-agent chemotherapy. So different chemotherapy is given in the drip at different timelines according to a regimen. For example, in the acute myeloid leukemia, they get a regimen known as the 3+7 regimen, which is 2 drugs, one given for 3 days and another one for 7 days. And this, and in the case of ALL, they get different regimens. The one we use commonly is called the KLGB regimen, and we give that once a week for the first 4 weeks. And so this is called the induction chemotherapy. So this induction is aimed at trying to kill all of these malignant cells. Of course, these therapies are not targeted, and they cannot tell the difference in the vast majority of them between normal cells and malignant cells. And so they kill all of the cells. And that is why one gets the side effects associated with chemotherapy. And these side effects are the blood counts go lower, and hence you can get more bleeding and more anemia and more tiredness, and of course, life-threatening infections. But there are other side effects associated with it. Some of the chemotherapies may affect the heart, some affects the neurological system, some can affect the kidneys, some even affect the liver. And so they have different side effects. In the case of the chronic leukemias, the CML is a very interesting case, in fact, and there's been a lot of development in CML and some spectacular development, alhamdulillah, over the last 25 years, in which they developed a targeted therapy known as the TKIs, or the tyrosine kinase inhibitors. You'll remember I told you earlier that CML is associated with a genetic abnormality, this Philadelphia chromosome, and the development, or rather the finding of this, discovery of this genetic abnormality has allowed the development of a drug, a medication that's targeted at this particular genetic abnormality. And these are called the tyrosine kinase inhibitors. The first one, in fact, was kind of released in the early 2000s, or between the late 95 to 2000. This was called imatinib or Gleevec. And in fact, the results of this therapy, alhamdulillah, have been nothing less than spectacular. The natural course of the disease of CML prior to the development of this was that the majority of patients, in fact, 75% of patients with CML prior to the TKIs, prior to Gleevec, would get into a acute leukemia, or what they call blastic phase, in 5 years. And the lifespan thereafter was 6 to 9 months with or without treatment. So that's 75% of patients. With the discovery of this particular drug, the prognosis has changed significantly, in that in 5 years now, 75% of patients are now in a complete molecular remission. In other words, there is no evidence of the molecular abnormality. So this is a 180-degree turn. This is about a turn that we see with politicians on a daily basis, and that illustrates to you how spectacular this turn is. It's completely, a different course. So that's the tyrosine kinase inhibitors that are used in CML. In fact, the first one, as I said, was Gleevec. There are another 3 or 4 now that are developed, because these cancers are extremely savvy, they're foxy, and they develop mutations against the drugs. And so this has led to the discovery of new drugs. So imatinib was the first generation. We now have nilotinib and dasatinib, which are second generations, and even ponatinib, which is the third generation, even a fourth generation now, one in the form of asciminib. So that's the CML. The CLL specific treatment is really interesting in that all patients with CLL, chronic lymphocytic leukemia, do not need therapy. I'll repeat that. Everybody with CLL does not need therapy. And this may sound surprising to you, that I have a cancer and why do I not get any treatment for this cancer? And the reason for that is because patients with early CLL or good prognostic factors who don't have bad genetics will not benefit from early treatment. In fact, they will be harmed by early treatment because of the harms of the chemotherapy. So the first group of patients that we treat, we put them in what we call the watch and wait territory, where we only monitor your blood counts on a monthly basis, and we see whether those lymphocytes or these malignant lymphocytes are increasing. And when they double in 6 months, or the patient develops significant symptoms, those B symptoms that we talked about, then we start treatment. And this treatment essentially is chemotherapy again, but not just your standard chemotherapy. There is a new targeted therapy. When I say new again, I mean in the last 15 to 20 years, something called rituximab, which is a targeted therapy, which is targeted at these particular cells. And this leads to good response and also leads to less side effects. And this main regimen that we use is called RFC, rituximab with two other chemotherapeutic drugs, fludarabine and cyclophosphamide. But there are also now newer therapies in the form of tablets, so oral therapies that have been developed for CLL, and some of them with really good results. Cost is often an issue in drugs, and certainly in all of the spheres of hematology, any of the blood disorders, the cost of drugs is sometimes prohibitive, very much so in the state sector where I am. We have a limited supply and sometimes no supply of some of these drugs. So this is an overview of the leukemias. I hope I'm not boring you. It's 30 minutes now. I'll try and move on a little bit faster to the other disorders. So let's talk about the lymphomas. So lymphoma, again, are cancers of the white cells, essentially, but the lymphoid cells. And you'll see that I wrote the lymphatic system, so that involves the lymph nodes, and also the bone marrow to an extent, and sometimes the spleen and even the liver, which are the extra lymphatic organs. They may involve some of these organs. And there's two main types of lymphomas. This is the Hodgkin's lymphoma that you see here, and the non-Hodgkin lymphoma. There's a difference in the presentation of these. The Hodgkin lymphoma essentially is a disease of young people. The peak incidence is within the 15 to 30 age group. Yes, you can get Hodgkin's when you're older, but essentially the 15 to 30 is the largest group of patients with Hodgkin lymphoma. Non-Hodgkin's lymphoma, on the other hand, is essentially a disease of older patients, generally over the age of 60, except in our country with the advent of HIV. So HIV has caused a significant burden of non-Hodgkin's lymphoma. And this happens, of course, in younger patients because more often younger patients are infected with HIV. And in fact, Hodgkin's is very important to HIV because it is classified as an AIDS-defining disease. So the Hodgkin lymphoma and non-Hodgkin's lymphoma early on in the disease have an extremely good prognosis. Hodgkin's, in fact, is probably the cancer out of all cancers with probably the best prognosis up front. I talk about prognosis and I talk about curing and all of that loosely. We are very well aware that we are not in control, of course, of cure. Cure belongs to Almighty Allah subhanahu wa ta'ala. As doctors, we are instruments, hopefully, to this, and only with His permission, cure or remission occurs. So whenever I talk about cure, please keep that in mind. So Hodgkin's lymphoma, the literature shows that in the early disease, so stage 1, stage 2 disease, the cure rate is in the region of 90%. This is really spectacular. It's not as good with non-Hodgkin lymphoma, but both of these are curable diseases. How do they present? So they present with these swollen lymph nodes, as we say, and sometimes it's not necessarily a lymph node, it may be a mass, or what we call an extranodal mass, and that can be found in many different organs, sometimes in the skin, sometimes within the chest, in the abdomen, and different areas. We even see them in the head and neck. So they can present in many different areas. But they also present with these B symptoms that I alluded to earlier in talking about CLL, and that is this fever. And the fever tends to be a recurring fever over 38 degrees, and it continues for like at least 2 weeks. Then they also have night sweats, but this is not your average night sweats. These are drenching night sweats. In other words, you get wet, your pillowcase gets wet, your clothing is wet, you need to change your clothing. So this is drenching night sweats. And then significant weight loss. And the weight loss, we say to qualify for being a B symptom needs to be more than 10% in the preceding 6 months. So significant weight loss. Let's talk a little bit about the diagnosis of these disorders. Essentially, the diagnosis is made on a biopsy. And this biopsy is, of course, of the lymph node or perhaps even of a mass that is found. And the biopsy will then reveal the diagnosis. They will look at this under the microscope, but they will also subject it to certain what we call stains or immunohistochemistry, and sometimes even genetic testing. Some of these lymphomas are associated with particular genetic abnormalities, and the diagnosis will then be made. So once we make the diagnosis, of course, patients need supportive care because this lymph node or mass may be causing obstruction, sometimes even causing significant pain, and these things need to be, of course, addressed. But the main treatment for the lymphomas is actually chemotherapies. Different types of chemotherapies for both of them. There's many different regimens, but often they are given as multi-agents. So let's take, for example, Hodgkin's lymphoma. They're given in the first-line treatment a regimen known as ABVD, which is 4 different drugs: adriamycin, bleomycin, vinblastine, and dacarbazine. These are 4 different chemotherapeutic agents, and they're given periodically every 2 weeks for a total of 12 cycles. We, of course, when the diagnosis is made, one needs to do a staging, and the way to stage this is either a CT scan or a PET scan, and this will then identify the areas where there is involvement of this lymphoma, and by virtue of that, we can stage it. We use what we call the Ann Arbor staging system, and we stage them. In the case of non-Hodgkin's lymphoma, the vast majority of patients will get a chemotherapy regimen known as R-CHOP, and you heard about R earlier, which is the rituximab targeted therapy. So that's the monoclonal antibody, together with 4 different chemotherapy agents known as CHOP, which is cyclophosphamide, adriamycin, vincristine, and prednisone, and we give this again in cycles, but these cycles are given every 21 to 28 days, and we generally give 6 cycles of this chemotherapy, and then we repeat the scans to see what is the response to treatment. Some patients with the lymphomas may require bone marrow transplants, and I'm sorry, I forgot to mention a very important treatment, of course, in the acute leukemias, and that is the hematopoietic bone marrow transplants. I don't think that is within the spectrum of this talk, but perhaps in the question and answer session, we may talk a little bit about transplants. But patients with lymphoma who don't respond to first, second, and third line treatment perhaps may need transplants. So that is the lymphomas. Let's talk now briefly about a third hematological malignancy, and this is the multiple myelomas. In fact, multiple myeloma is one of the most common hematological malignancies in patients of African origin. In fact, in the US, studies have shown that patients, African Americans, this is the most common hematological blood cancer in African Americans. I think that perhaps in South Africa, multiple myeloma would be more common, would be the most common, but it isn't. The most common is actually lymphoma, and the reason for that, of course, is the high burden of HIV that we have. But multiple myeloma is a very common hematological malignancy, relatively speaking, of course. So what is multiple myeloma? It is a cancer of the plasma cells that you see there, and this is a cell that I did not depict in the slide earlier, but you will remember in the first slide I showed you the lymphocytes, and actually the plasma cells come from the lymphocytes. They are what we call terminally differentiated lymphocytes, and they are very important because they are responsible for the production of the antibodies. So you can see why the plasma cells are truly important. So what happens in multiple myeloma is that these malignant plasma cells then proliferate, they increase, and they take over the bone marrow, just like how you will see in leukemia. But the difference, or one of the features really of multiple myeloma, is that it's a multi-system disease. It affects several organs, and you'll see this, what I've termed here the CRAB symptoms, and this is a well-known acronym for the symptoms or the organs that are affected mainly in multiple myeloma, and is that patients have hypercalcemia, high calcium, they have kidney failure, which is a common presentation, they certainly have anemia, and they have bone pain. In fact, my professor, Professor Musa Patel, who is the probably premier, most amazing hematologist that I know, used to say that the most simple diagnosis for multiple myeloma is an older patient who presents with anemia and bone pain. This is one of the signs or the easiest way to consider a multiple myeloma. So they present with this anemia and they present with bone pain, but in fact, not just bone pain, a significant proportion of patients will actually present with a fracture. We call this a pathological fracture. In other words, a fracture that occurs without significant trauma. So patients may have a small fall or may even stretch. One of my patients, in fact, was closing his garage door and he fractured his spine with a simple activity like that. And that's because these plasma cells have infiltrated the bone and they cause lytic lesions. They eat up the bone, so to speak. And you can see this on the X-ray. We call them lytic lesions. And hence they make the bone weak and patients get fractures. So how do we diagnose multiple myeloma? Again, patients may present with these symptoms associated with kidney dysfunction, with anemia, the fractures, the bone pain, as we said, and then they present with these increased plasma cells in the bone marrow. So we do a bone marrow test and we see these plasma cells. In addition to that, a large proportion of patients will present with these paraproteins which are abnormal. You remember I said that plasma cells are responsible for the production of antibodies. And what happens here is they produce abnormal antibodies, and we call that a monoclonal paraprotein. So we can test this in the blood. And in fact, not only is it important for the diagnosis, it's extremely important for the to monitor the response to treatment. So how do we treat patients with multiple myeloma? Uh, Before we get there, multiple myeloma, I forgot to say, is essentially a disease of older patients. In fact, in South Africa, or rather worldwide, the average age of patients with multiple myeloma is 69 years old. In South Africa, it's a little bit lower than that. It's 62 years old. And so these are older patients, not elderly. I say old patients. 62 is not old in medical terms. And so these are older patients who then present with these symptoms. And we then do this bone marrow, as we said. All right. So once we make the diagnosis, again, the treatment is the supportive therapies because they present with this anemia and they sometimes need blood transfusions. They don't often have very low platelet counts, but they could, and they may need platelet transfusions. They certainly get infections. So infections is a very common presentation in patients with multiple myeloma. And again, you can understand that the plasma cells are not producing normal antibodies, and hence the body is susceptible to infections. And of course, in older patients, they may have other diseases, they have comorbidities, they may be on other treatments, which make them even more susceptible to infections, and hence they get infections. And so the treatment is to support them, treat these infections, perhaps give transfusions. Sometimes we even give injections to increase the red blood cells, known as erythropoietin. You may have heard of it. So we give these injections. But the main cornerstone of treatment really is, again, multi-agent chemotherapy. And there are, fortunately, alhamdulillah, newer therapies are available in the last 10 or 15 years in which patients have seen some great benefit. This used to be a disease that had an extremely poor prognosis. In fact, the worst group of patients, their prognosis was 6 to 12 months. The best group of patients had 60 months. We are seeing significantly better responses to therapy now with the newer agents. There are one or two newer agents. One is the group known as the proteasome inhibitors, a drug called bortezomib or Velcade, and the other group is the immunomodulatory agents. There's a drug called thalidomide, which you may have heard of, which was used some 60, 70 years ago for nausea and vomiting and caused problems with infants, with pregnancy in infants and newborns. That drug is now repurposed for multiple myeloma, and there's a second generation form of that drug known as lenalidomide, and this drug has shown some significant benefit. So that's the multiple myeloma. How am I doing for time, Molana? It's already 45 minutes. Can I perhaps go on for another 10 minutes?
Yeah, you can go on. You can go until past, and then we'll leave some time. But we don't have to stop at 9. What we can do, you can go until past. Then whoever needs to leave at 9 can do that, and then we can carry on if there are questions. Is that
I don't
okay
want to
with
put
you?
It's perfect with me, but I don't want to put them to sleep, Molana. Perhaps I've already put a few people to sleep.
It's cold now, so I think everyone will be asleep. Mashallah.
Okay. Excellent. So just a few of the other miscellaneous blood disorders. I'm not going to talk about sickle cell disease. It's not extremely common in South Africa. It's a disease that's more common in certain other parts of the world, mainly Central and Central Africa and West Africa. It's an inherited disorder, but more pertinent perhaps to us is a inherited blood condition known as thalassemia. Now, one very important thing to understand with thalassemia, and we have many patients coming to me who say, I have thalassemia, and is thalassemia the cause of my problems? And perhaps it is or it isn't, but one needs to understand that there's two different types, and this is thalassemia minor and thalassemia major. Now, what's the difference between the two? Patients who have thalassemia major have the disease itself, in which they require blood transfusions for a very young age. And often this is diagnosed at the age of 6 to 9 months, where where babies are seen to be very pale, and they may be lethargic. They may not be as active as normal children, or as children without the thalassemia, and the blood test reveals that they're very anemic. So this is thalassemia major. The thalassemia minor is when the patient is only a carrier of the disease, and the reason for this is that the red blood cell production is dependent, of course, on the genes, and for one to get the disease, one needs to have the abnormal gene from both your mother and your father. So if you have both, then so in other words, if a couple have who are both thalassemia minors have a child, there is a 25% chance of them having a child with thalassemia major. This doesn't mean that if they have 4 pregnancies and 4 children, that definitely one will have thalassemia. No, it means there's a 25% chance in every pregnancy. There are certain families, and I have one family of patients who have more than 6 children, and I think the seventh one, perhaps, or I may be a little bit wrong with the numbers, but the last child had thalassemia. So the other 6 children were perhaps either normal or carriers. So thalassemia minor is only a disease in which the carrier has part of the gene, and they generally do not present with any clinical symptoms. They may have a mild anemia, but the biggest problem is, of course, if that individual marries somebody with who's another carrier. Of course, they have then a chance of having a child with thalassemia major. So thalassemia major is the disease in itself, and this is the condition, as I said, in which patients require chronic transfusions. So from a very young age, sometimes every 2 weekly, sometimes every 3 weekly, and some patients every 4 weekly will require transfusion. So they come into hospital and need to get a transfusion. The problem, of course, with the transfusion is that, of course, it means that somebody has to come into hospital. Of course, it's time consuming, but more important than that is that patients get iron overload, because when we transfuse somebody with red blood cells, each unit of red blood cells contains about 250 milligrams of iron. And as we saw earlier, iron deficiency anemia is not good for you. The converse is that iron overload is also bad for you, because this iron goes and deposits in the organs, sometimes the spleen, the liver, certainly, and even the heart, and of course causes dysfunction of these organs. So iron overload is one problem. Of course, patients with thalassemia who get transfusions can get what we call transfusion-related problems, so transfusion-transmissible diseases in the form of infections, and HIV used to be a problem in the past. Hepatitis was a problem. It is less of a problem, and of course, this question comes up often about the risk of transfusion. In fact, our blood bank is probably amongst the most sophisticated blood banks in the world. We do the most sophisticated testing more than anywhere else in the world. In fact, even more than the US and Europe. In the last, I think, 8 years of the new testing that was done, we haven't had one patient, to my knowledge, that has contracted HIV from a transfusion. But yes, that risk is definitely there. In fact, the risk of hepatitis B is probably larger than the risk of HIV. Then there are other risks. There are other risks associated with transfusions, like allergic reactions, etc. Thalassemia, the treatment apart from the blood transfusions, of course, the prevention of iron overload by giving medication, and these called chelators, iron chelators. And fortunately, in the last 15 years or 20 years, oral iron chelators are available. In the past, it used to be injection that had to be given underneath the skin subcutaneously for 8 to 12 hours every night. But the oral iron chelators have changed that, fortunately. So that's one of the other important treatments. Another treatment for thalassemia is a bone marrow transplant. And so bone marrow transplant has been used fairly commonly, not as much in our country, but certainly overseas in areas where thalassemia is more common. Incidentally, I said that it's more important to us because thalassemia is common in the Mediterranean area, so Italy, Greece, and certainly the subcontinent. So So amongst Indians, thalassemia is fairly common. Um, I was saying about bone marrow transplants. So in Europe and to a lesser extent, we certainly are doing bone marrow transplants for patients with thalassemia. Let's move on now to ITP, and ITP are low platelets. This is a condition perhaps that you will see. It's patients who present with very low platelets, and we said earlier that platelets are responsible for prevention and stopping of bleeding, and these patients then bleed easily. It's a condition that's very well treated. Sometimes the treatment is not easily tolerated, but there's certainly fairly significant amount of medications and treatments that we can use for ITP. DVT, or deep vein thrombosis or pulmonary embolus, is also part of the spectrum of the blood disorders. This is in which patients have clots. We know about clots in the legs and in the lungs, certainly. This can occur in other parts of the body, of course. Often it is related to what we call acquired risk factors like surgery and pregnancy, also a prolonged immobility. The one is called economy class syndrome, where you sit in an aeroplane for more than 6 hours and you don't move. And because of blood stasis, the blood is not moving, one can develop a DVT. But the other causes or the inherited causes are also there. So we have some inherited causes in which patients have an inherent risk of developing clots. So this is the miscellaneous disorders I wanted to quickly go through. Perhaps of importance to this discussion is when to see a doctor. The best answer is probably never. Uh, no, I'm joking. Sometimes you have to see the doctor. Unfortunately, you'll have to come and see me. Um, and these are some of the reasons when you'll want to see a doctor. So persistent fatigue, certainly tiredness, weakness, shortness of breath, swelling of the legs, which is a sign of cardiac failure, is one of the reasons to see your doctor. Unexplained bruising or bleeding, in other words, we're talking about now spontaneous bleeding. So if you get injured and you bleed, perhaps that is, perhaps certainly this is normal, but if you bleed more than expected, either with trauma or no trauma, then this is another reason that you should see your doctor. Swollen glands, as we talked about earlier in the lymphomas, and definitely night sweats. Now, again, please, we're not talking about your average garden variety night sweats. We're talking about trend, you have to change your clothing. And then, of course, last but not least, frequent infections, or perhaps even sometimes unusual symptoms. I know I've left the door open there with unusual symptoms to perhaps everything, but what we're trying to create here is not paranoia. So everybody with fatigue or unexplained bleeding or even a gland does not have a blood cancer. In fact, the most common cause of glands is infections. Simple throat infections can give you glands in the neck, and one should not then be paranoid about those kind of things. So how do we keep healthy? And really, this is stuff that you know, that I really don't have to tell you. And some of these advices perhaps is something that I need to follow myself. So I'm being a bit of a hypocrite, and that I'm referring to the stay hydrated and active. Before you were thinking it's not the other things, it's the stay hydrated and active that I need to work on myself. But certainly your diet is important. And we know that not just for blood disorders, for general health, diet and exercise, activity is extremely important. Not blood disorders, as we say, we're talking about cardiac disorders, kidney disorders, and the likes thereof, in all of these things. I mean, nobody needs a lecture on smoking. We all know well enough about the harms of smoking, certainly. And so that's fairly easy to understand. And then regular health checks. The only reason I put that there is so that I don't go out of business. And then, you come and see me from time to time. No, I joke. Of course, depending on what the condition of the patient is and what underlying problems there are, one needs to have health checks from time to time. And I think that's about it for my presentation. Maulana, I'm happy to take questions and have a discussion.
Gee, so I think we're going to keep it open. If anyone wants to ask something, you can just put your hand up and then we'll give you a chance. And thereafter, if there's anything that comes discussion. So there's a question here from a doctor. What is the incidence of allergic reaction to parenteral iron? Dr. Saab, you got me on that one?
Sorry, Molana, I forgot to unmute myself. I hope you can hear me now.
Now we can hear you, T.
I was saying Jazakallah Yusuf for that question. Yusuf is an old friend of mine, and
MashaAllah.
Yusuf had to start with a tough question. Yusuf, thank you very much, Yusuf. No, no, just joking. So yes, there is certainly, as we referred to, allergic reactions to parenteral iron, and it depends on the agent that one uses. So one of the earliest agents that we used to use was something called Venofer, and Venofer is still very convenient to use because it's cheaper, it's easy to give, and it can be given over a short period of time. But the allergic reactions with Venofer, the first generation of these iron, is more than with the later ones. So the first generation was Venofer. We then have the other ones. Ferinject is another one of the later agents, and in the middle we have something called Cosmofer. There are one or two other ones. The incidence of the allergic reactions is not necessarily understood. More important is the anaphylactic reactions, and these occur less than 1%. Allergic reactions are fairly common. So this will be, burning at the site of the infusion. Some patients may have some itching and the likes thereof. I can't remember, Yusuf, the exact numbers. Perhaps I think more important to us is the anaphylactic reaction. As I say, it's less than 1%. It's certainly even lower in the newer agents. Very important is the rate actually that we give it in terms of the allergic reactions. So if we give these drugs too quickly, over a shorter period of time, patients tend to have allergic reactions far more common. In the case, for example, of Cosmofer, which is one of the drugs that we use, this drug is to be given over 6 hours. One will always do a test dose for 15 minutes and a small dose of Ferinject with 5 milligrams or 5 mils rather of solution, and we wait 10 minutes and see if there's any reactions. But by giving it slower, certainly we will reduce the incidence of allergic reactions. I hope that answers the question, Yusuf.
There's another question here. Can polycythemia and porphyria be discussed? I'm not sure what does that.
Let me get to that, Molana.
It's on the chat there. There's sorry man, I can't pronounce those two words there.
Polycythemia, did Molana?
Yeah, and
I'm trying to
porphyria
read
be
it here.
discussed.
Okay, so porphyria is a part of it is within the realm of hematology, and some of it is within the realm of gastroenterology. Essentially, it is a disorder in which there is abnormal proteins or porphyrins that are produced, and this affects, in the case of the blood disorder, the blood formation system. And the excess of these proteins then lead to the clinical phenotype. They are not very common disorders. The protoporphyria or the erythropoietic protoporphyria is one of the more common ones in the blood disorders, but the one that's most common actually is one that I've seen in people of Afrikaans origin. That's the porphyria cutaneatada, and this one affects the liver. But it's not common, it's not most often. The more common ones are within the realm of gastroenterology. Then there was a question you said on polycythemia, Molana.
Gee, the person asked the same question, asking polycythemia and that other one to be
Polycythemia.
discussed.
Okay, so polycythemia is far more common. It's certainly within the realm of the hematological disorders. It is the converse of anemia. So as we said, anemia is a reduction in the red blood cells. Polycythemia is the opposite, and this is an overproduction of the red blood cells. So what happens here is that rather than having a low HP, you'll have an extremely high HP. Now, polycythemia again. Very importantly, one needs to ascertain the cause. There are two different causes. One is what we call the secondary causes, and the other is the primary causes. So the secondary causes are essentially related. You would call this an appropriate polycythemia. The polycythemia is happening for a good reason. And those reasons are mainly respiratory disorders, so lung disorders, cardiac disorders, so the cyanotic congenital heart diseases, and some other. some other ones like kidney disorders. So in the lung disorders, one can understand why this happens, is that, of course, we know that the function of red blood cells is to carry oxygen to the rest of the body. And this oxygen content is then, and this is an absolutely amazing mechanism, like most things in the body. One can only be at awe when one looks at how these things work. So what happens is that when there's a decreased amount of oxygen, the red blood cells, as they move through the kidneys have oxygen sensing mechanisms. And when they sense that the oxygen is low, they produce this hormone known as erythropoietin. And erythropoietin is the growth factor that stimulates the bone marrow to produce red cells. So if there is an oxygen or low oxygen content in the body, like somebody who's got lung diseases, asthma, and sometimes, or more often in patients with chronic obstructive pulmonary disease or chronic obstructive airways disease, like we see emphysema in smokers, or people who have occupational lung disorders, or even people who are living at high altitude. They have reduction in the oxygen concentration that is in their blood, and that produces too many red cells. Now, what's the problem with that? Because that sounds like a good thing. Of course, it's a good thing when it's appropriate and it's enough, but when it gets too much, then patients present with thromboses. So they present with clots. And these clots can occur like in the form of DVT that we talked about, and also can form in the form of pulmonary emboli or clots in the lungs. And sometimes, really, they may even have strokes as a result thereof. So that's the secondary polycythemia. The primary polycythemia is when the bone marrow, for no good reason, produces too many red cells. Now, when I say no good reason, I actually mean that there is a reason, and this reason is an abnormal genetic mutation. And this is known in about 95% of cases to be the JAK2 mutation, Janus kinase mutation. And this JAK2 mutation is essentially the light switch of the bone marrow to turn on and off erythropoiesis, or the production of red cells. And this light switch is defective. And as a result of this defectiveness, it's always in the on position, and irrespective of the blood, or irrespective of the kidney sensing whether there's low oxygen levels or not, it continues to produce red cells, and hence you get this condition called polycythemia, and specifically it's known as polycythemia vera, and that's the polycythemias. I hope that takes care of that one, Molana.
So Dr. Zaid, a good friend of mine, asked, he said, excellent talk. Could you please touch on Burkitt's lymphoma recurrence, especially in someone in the mid-40s?
Yes. So Burkitt's lymphoma is in the realm of the non-Hodgkin's lymphoma. So you remember we talked about Hodgkin's lymphoma and non-Hodgkin's lymphoma. Burkitt's lymphoma is a non-Hodgkin's lymphoma. There are essentially two types of Burkitt's lymphoma. There's the endemic type, and that is the one that's seen in particular areas associated with young children. This is a pediatric lymphoma. But we also get the pandemic type, and this is the one associated essentially with HIV. But please, not all patients with Burkitt's lymphoma have HIV, and not all patients with lymphoma, of course, have HIV, but certainly has a higher association with HIV. So Burkitt's lymphoma is one of the aggressive lymphomas. It is one of the aggressive non-Hodgkin's lymphomas. It has a very high proliferation index. It grows very rapidly, and it presents very often with what we call extranodal disease. So not just the glands, also with masses or disease or tumors in other parts of the body. The bone marrow certainly is one area where you can find it, certainly the liver, the spleen, and in fact, it can even affect the CNS, on the central nervous system or the brain. So this Burkitt's lymphoma has certainly a high recurrence, and the reason it has a high recurrence is because it's such an aggressive lymphoma. It responds initially well to treatment, and patients can go into remission very often, but they often recur. The reason for Burkitt's lymphoma is that there's a genetic abnormality. This is known as the MYC mutation, the MYC mutation, and there's a translocation of the genes of chromosome 8 and 14. And this leads, in not all cases, but in some of the Burkitt's lymphoma, to the formation of the disease. Now, diagnosed in the mid-40s, so this is a fairly young patient, of course, with Burkitt's lymphoma. They will require certainly aggressive chemotherapy, no question. And in the case of these chemotherapy regimens, they sometimes need maintenance therapy. When they do relapse, one needs to use salvage therapy, and in some cases, bone marrow transplants are indicated for patients with Burkitt's lymphoma. I see another question which is very, very pertinent, Maulana, if I may,
Sure.
by uh, Dr. Zair. I think it's Dr. Zair Esop. Um, this is the halal status of Klexane. And in fact, I was talking about this with somebody 10 days ago, and I was thinking about it prior to that. And certainly there is an issue with the halal status of Klexane. So what is Klexane? Klexane is enoxaparin. It is a blood thinning agent. It's a blood thinning agent. It's a blood thinning agent, Klexane. It's enoxaparin. And patients, some people who have had it would perhaps remember that these are those little injections that you get in your abdomen, on the side of your stomach, if you've had a clot or to prevent clots rather. So yes, Klexane is of porcine derivative, so from pork, pig derivative. And unfortunately, of course, that is the case. The issue with the use of Klexane, and I'm by no means a learned person or a scholar, not even close. But my understanding in the past was that Klexane was one of the only ones available. And of course, these conditions like clots in the lungs or in the legs are life-threatening conditions. And hence we used to use Klexane, and we still use it. Fortunately, however, there are now alternatives. There are alternatives in the form of oral therapies, and one of them, or rather the group of drugs are known as the DOACs, the direct oral anticoagulants. People may have heard of them, Xarelto or rivaroxaban, and there's other ones, Eliquis, apixaban, edoxaban. There's three or four different agents now. The good thing about these are that they don't need to be used in conjunction with Klexane. In fact, in studies treating patients with pulmonary embolus, clots in the lungs, they have shown equal effectiveness to Klexane. So that's one option. If one needs to use a parenteral agent or an injection, there is another drug known as Arixtra or Fondaparinux. Fondaparinux, to my knowledge, is not produced from a porcine origin. We are actually looking into it a little bit more detail. It's a drug that was not freely or easily available. It is now. It had another indication. It was used in something called HIT or heparin-induced thrombocytopenia, and that mainly where the use was. So it is available now, and it is a drug that's um, probably better to use than Klexane in terms of its origin. The difficulty with Rixtra is it may not always be available in every pharmacy. And the second problem with Rixtra is that it is certainly more expensive than Klexane. And in medicine, unfortunately, one needs to take into account the cost of things. Not everything is affordable. Certainly, different people have different levels of financial independence or affordability, and one needs to take this into account. But certainly, these alternatives are available.
There's quite a few questions on the chat. I don't know if you want me to read it or you just want to go through it.
I can try and go through them, Molana, if I miss any.
So the one is Masiha. She asks, what is recommended for someone who suffers from low iron? Is unexplained bruising linked to low iron levels?
Okay, so that's an excellent question. The first part you said, Molana, sorry, was?
What is recommended for someone who suffers from low iron levels?
Okay, so as we alluded to in the talk, the first most important thing is to find out what the cause is. Because if we don't find out the cause, irrespective of what treatment we give, we're going to end up in the same position, and that treatment is only going to be short-lived. So that's the most important thing. And as I said earlier, it's about looking for bleeding. So if there is any bleeding, this needs to be sorted out, number one. Number two, of course, is to use the iron therapies that we talked about earlier. So either oral iron or the intravenous iron is the two other things that we can use. And sorry, Molana, the last part of the question was?
Is unexplained bruising linked to low iron
Oh,
levels?
yes. So that's an excellent question. And to my knowledge, unexplained bruising is associated, but it's not one of the common things. It can be as a result, um, very, very rarely in certain patients, certainly um, they do have low platelet counts. It can happen with iron deficiency. But more importantly, excuse me, it should be ascertained whether the cause of the anemia is a bleeding disorder. And if somebody has a concurrent or concomitant bleeding disorder, then certainly one will have bruising. And this bruising will then be seen in conjunction with the iron deficiency.
What is the recommended treatment for ITP?
Okay, so the treatment of ITP is essentially a stepwise approach. The first important thing is to decide whether the patient needs treatment. And this is something that we need to make very clear to patients. And I say it at the outset to our patients with ITP, is that the aim of treatment for ITP is not to get a normal platelet count. We should not be chasing the number one. Number two is not all patients with ITP need treatment. So you have ITP and you have low platelets, certainly we know this. But if your platelet count is above 30, 30. And remember that a normal platelet count is 150 to 450 in the vast majority of people, irrespective of age or gender. Generally, that's the ballpark figure. But if your platelet count is more than 30, then and there's no bleeding, then one does not need to treat the ITP. The reason for that is two or threefold. Firstly, because the risk of spontaneous bleeding, in other words, bleeding without trauma, with a platelet count above 30 is fairly low, number one. Number two is that there's a proportion of patients with ITP, particularly younger patients, who will go into a spontaneous remission. In other words, their platelet count will recover without any treatment. And that's another reason why we don't want to treat the ITP. But if the platelet count is above 30 and the patient is bleeding, then certainly we'll want to treat it unless there's another cause of the bleeding. For example, if you have piles or ulcers, then certainly you can bleed with ITP more than the average person. Um, or one of the other reasons, if somebody is about to have a procedure, a surgical procedure. So if we're going to leave you at the mercy of our friends, the surgeons, then we certainly don't want a platelet count of 30. Depending on what the procedure is, we will have to get a higher platelet count. So if it's general surgery, for example, a hernia repair, then perhaps a platelet count of 50 is enough. But if it is neurosurgery, then one will want to have a platelet count higher than that, in the region of 100. So important principle to remember. The second thing is about the actual treatments. They are different, and as I say, there's a stepwise approach, but the vast majority of patients, as the first-line treatment for ITP, will get steroids. Corticosteroids or cortisone, better known as cortisone. This can be in different forms, in the oral prednisone, the intravenous dexamethasone, or even methylprednisolone, sodium medrol, any one of these IV or oral agents will be used. Which one you choose will depend on the individual patient. Different patients will require different treatment. That's the first line of approach. Then there are other lines of approach, like other immune suppressants, because the reason for ITP really is that the body has produced antibodies against your own platelets and it destroyed your platelets. So majority of the treatments are then aimed at suppressing the immune system to not produce these antibodies. So steroids are the first one, as we said. Then other immune suppressant agents like Imuran or azathioprine, there's dapsone and danazol. We use some of these. Rituximab, which I talked about earlier, that we use in the treatment of the lymphomas. One can use rituximab. Then there are a new group of drugs. These are known as the thrombopoietin agonists, and thrombopoietin is the hormone that stimulates the production of platelets. You remember I talked about erythropoietin earlier that produces red cells. Thrombopoietin is the one that produces platelets. And this thrombopoietin can be given in a synthetic form, either in the tablet form, the one is called Entrombopeg, and the other is an injection known as Romiplastin, and these have shown benefit also in patients with ITP. The problem with these drugs is that they are extremely expensive. In fact, for an average adult, per month, they cost in the region of 40 to 60,000 rand, depending on what the dose is, depending on the weight of the patient. One other form of therapy for ITP that perhaps is not talked about enough is the splenectomy, where one can remove their spleen. The reason is because the destruction of this platelets essentially takes place in the spleen, and the spleen, in fact, is one of the best curative therapies for ITP. Of course, it does come with potential problems, surgical problems, which are not very common, but more importantly, infection problems, because of course the spleen is really important in the prevention of infections, and hence that's one of the potential problems. But splenectomy certainly is a form of treatment. One that I didn't talk about is something called polygam or IV immunoglobulin. This is immunoglobulin with antibodies given in the drip, and this is given over a period of 2 to 5 days, and there's certainly been good responses with this drug as well. But that's basically breakdown of how we treat ITP.
Another question coming. I'm sickle cell thalassemia sufferer, currently on Hydria. Blood transfusions have been done more often compared to previous years. Would just like to know, besides Hydria, is there any other treatment available in South Africa?
Certainly the cornerstay of treatment is hydroxyurea. Of course, blood transfusions, as you indicated, are important in the treatment of sickle cell anemia, and patients who are requiring chronic blood transfusions must watch out for iron overload and, of course, need to treat those. The other treatments in terms of the of sickle cell anemia, of course, is the prevention of other problems. So patients with sickle cell anemia can have what we call an autosplenectomy. So their spleen will get infarcts and die, and hence they get infections. So these patients require antibiotics, sometimes vaccination as well. So that's the other things. Then, of course, they need perhaps folic acid, and these are the supportive therapy. Bone marrow transplants are certainly something that can be used for sickle cell anemia. These are done. It can be done, of course, here as well. Then there are also some newer therapies that are currently being tested. Some refer to nitric oxide or nitric oxide agents. These can be used also in sickle cell anemia. And there's one or two herbal preparations that I've heard of that are used in North and West Africa that also have shown some benefit. I'm not aware exactly of these, and I've never used them, but I've heard that these are available.
Another question coming in. Jazakallah, Dr. Karodia, for a good overview of the hematological diseases. My question is, what do you advise a couple who both have thal major on how to plan their family? IVF and gene testing of the fertilized eggs, also knowing the cost of this is high.
So this is two individuals, both who have thalassemia major. Is that correct, Molana?
Both have THAL major, so I'm
Okay,
assuming
both are
it's that.
thalassemia majors. Absolutely, absolutely. Okay, so if both patients have thalassemia major, of course, the chance of having an inf or child with thalassemia major extremely high. So what do we do? The one method that perhaps is the best method, or may even be the only method, is this pre-implantation genetic diagnosis. So what is pre-implantation genetic diagnosis? What we do is essentially we do in vitro fertilization or IVF, as you know, normal IVF. And then at the 8-cell stage, the the one cell is taken out and tested for thalassemia. If the cell, if that embryo does not have any thalassemia major, certainly it will have thalassemia minor, there's no question. But if there's no thalassemia major, then this embryo can then be implanted into the mother as normal, and the pregnancy can take place as normal. I do note and I concur that this is expensive, absolutely, and it's not done very often here, but certainly this is one of the other things. Uh, I know this is perhaps not answering the question directly, and some people think that this is, a cop out. I'm not answering, but one must never forget the options of course, adoption. And that's also one of the things that we advise patients as a possibility.
Your friend again, Dr. Yusuf, asks, can you please discuss iron supplements in infants and toddlers?
Yes. So I can't very coherently discuss this because, as you know, I'm an adult hematologist. Uh, but certainly some of these products that we talked about are available for children. Now, again, with children, it's difficult because one needs to identify when it is physiological iron deficiency versus pathological iron deficiency. Because as we said, it's fairly common. In fact, the incidence of iron deficiency in the 2-year-old is the highest. That they have a physiological iron deficiency. But once we've identified that this is a pathological iron deficiency, of course, then looking for the cause, and often, not often, but some of the time in these infants, it will be gastrointestinal bleeding. So that's the first part. Again, I'm sorry to harp at this like a broken record, but we have far too many patients who are diagnosed with iron deficiency and are treated without looking for an underlying cause. And this is absolutely paramount. So we find this cause again, and can we give intravenous therapy? Yes, so intravenous therapy has been is indicated in patients, in infants. I'm not certain, certainly above the age of 2 can be used. The iron therapy options in terms of the oral is also available. So the ferry meds that I talked about is certainly available in the suspension form, in the syrup forms, and even the Sideral Forte that I talked about is also available in the infant forms. But I'm sorry, I can't talk in depth about the IV iron in children. I did look it up a little while ago, but because I don't see them very often, I honestly cannot remember. Yusuf, sorry about that.
Does ITP have a genetic link to its development?
To my knowledge, there isn't a genetic link to ITP. It is an acquired disease. So no genetic element that I know of.
I've been diagnosed with MSD. The Fulcastrum didn't want improve the WCB count. What would be the next step?
So the fulgastrum that the person, what was the disease, Molana?
MSD.
MDS, I would imagine, not MDS, myelodysplastic syndrome. Probably is myelodysplastic
Probably
syndrome.
that they must have just made a typo.
Yes. So myelodysplastic syndrome is a very interesting hematological disorder. I didn't touch on it because it's not that common. Essentially, it's a disorder more often of older individuals. It's when the bone marrow produces dysplastic or not normal cells. And as a result of this dysplasia, the cells that are produced don't have the longevity of normal cells. So these cells die early or just not produced well. We call this ineffective hemopoiesis, ineffective blood production. And so they present with these cytopenias and they have low counts. Um, the majority of patients actually with myelodysplastic syndrome are as a result of a genetic abnormality. So they have a genetic abnormality, and this is the basis of MDS. So the diagnosis of MDS often is based on what we call a triad. That's these low cell counts, the cytopenias, 2, the genetic abnormality, and 3, they certainly has an increased risk of developing acute leukemia. Now, the question posed by a questioner was, I've used filgrestrum, which is Neupogen, and Neupogen is not working for the myelodysplastic syndrome. And it is not uncommon for the Neupogen not to work because the growth factor of called the Neupogen is working on defective cells. Probably what needs to be done is go to the second line of treatment. Now, maybe I should just briefly talk about the treatment of myelodysplastic syndrome. Myelodysplastic syndrome is treated according to the risk stratification. So we stratify them according to low risk, intermediate risk, and high risk. Low risk patients who don't have significant cytopenias, are not transfusion dependent, don't need any therapy really. The second line of treatment in patients with low risk who have cytopenias, we give them growth factors. So the one is Neupogen, as you talked about, a filgrestrum, and there's even a long-acting one, a longer-acting or a pegylated version of this drug that one can also give, and it's called Neulasta. So that's the other one that one can use. Then, of course, the other growth factors, we talked briefly about erythropoietin earlier. This is available in an injection form, and one can use that. And also, we talked about the thrombopoietin agonist for ITP, and these can be used in myelodysplastic syndrome as well. And this is really the first line treatment. But patients who present with cytopenias who are refractory to these treatments have perhaps to be moved up to the second line treatment. And this is kind of the same treatment that we will use for high risk MDS. If the patient is young, fit enough, and has a donor for a transplant, then a transplant is the desirable option. The second line of therapy is chemotherapy in patients who have high-risk disease with excess blasts, so they have these leukemic cells also developing, they may need chemotherapy. But a very exciting development actually in myelodysplastic syndrome in the last 15 years or so has been a drug called azacitidine or Vidaza. And in fact, there's a second and a third line of them. The second one is called decitabine. And these are hypomethylating agents. These are drugs that are used in myelodysplastic syndrome with really good response rates. They're given as a subcutaneous injection for 5 days every month. So it's really easy to give, and there certainly have been responses. But for the individual case, of course, it's difficult to say without seeing what the patient is on, what exactly the treatment regimen, what is the prognostic staging system of this patient, what are the transfusion requirements, etc., etc. But Vidaza or azacitidine is one of the more exciting forms of therapy for this group of disorders.
There's a lot of questions coming in, Doc. I'm just going to go through a few. Is
No problem. Well, I'm
prednisone
sorry, I
a
can't
good?
see them for some reason or the other. I'm only
If you
seeing
just
the
check on
first
the chat, if you
one.
see the chat there, we're
Oh,
quite down at stuff. So is
let
prednisone a
me.
wonder drug, or are they dangerous for short or long-term use?
Uh, sorry, Molana, I'm just getting to my so I can see the chats here. While I'm doing that, Molana, you say is prednisone?
A wonder drug.
Yeah, that's debatable. I personally think that in the last 100 years, prednisone has been one of the most significant revelations in terms of treatment of different disorders. In the form of ITP, absolutely, it's an absolutely important drug. I don't think one can classify any drug as a wonder drug because every one of these will be associated with benefits and certainly will be associated with risks. But in the case of ITP, it is the first line treatment. More than 60 or 70% of patients will respond to prednisone. So it's really a good drug for this particular disorder. However, like every drug, and this includes the drugs that we use every day, all of them have some form of side effects. Yes, some are worse than others, but in the case of prednisone, there are certainly some significant side effects. So they suppress your immune system. So, of course, infection can be a problem. They affect the bones, so osteoporosis can be a problem. They can affect the eyes, and one can get cataract. And there are other disorders. They can affect your endocrine system, so one can develop a steroid-induced diabetes. So there are many side effects actually to prednisone. And so prednisone must be used correctly. And we do see in our clinic that there are patients who are on prednisone for far too long. Often we start it at a high dose, and the drug should be weaned off slowly, sometimes faster, sometimes slower, and to be weaned off to hopefully no prednisone or a very low amount of prednisone. If patients who are getting prednisone and are dependent on the prednisone, in other words, their platelet counts drop when you wean the prednisone, then it's probably time for the second line treatment or another form of treatment. But absolutely, it is a drug that is effective.
Is stem cell therapy an option for leukemia?
Absolutely. Um, so, so the stem cell therapy I think that you are referring to is probably the hemopoietic stem cell transplant, and this is the stem cell therapy that is used for leukemia. So certainly, however, Molana, I finally found this chat. I'm sorry, I was on the screen of the presentation. I couldn't see it, so
Okay, no, it's
I see
fine.
some of them now. Yeah, so stem cell therapy referring to bone marrow transplants or hemopoietic stem cell transplant is certainly an option. However, it should not be seen as the be all end all and some magic pill. It is not that. It should be used correctly in the correct patient. Um, it is not a therapy that is easy, no question, and it's not a therapy without significant complications. And some of those complications are life-threatening. But in the correct patients, absolutely, it can be a good option.
I have been diagnosed with CLL. Is the
Mhm.
immunotherapy injection the only treatment available for CLL?
No. So CLL, as we said, is a disease more of older patients, and one has to first stage the CLL. So we stage it using what we call the Rye and Binet staging system, depending on the involvement of the CLL. So if it is higher stage diseases, like for example, stage 2B and above, so this is where the patient's white blood cells are high, but the red cells become low and the platelets also become low. So that's in the case of stage 3 and 4, then certainly treatment is needed. As I said, prior to that, perhaps we can watch and wait. Now, there are many therapies available for CLL. There are milder, older therapies available in the form of a tablet, and the most common one is chlorambucil. This is a tablet we generally use in older patients because it's very well tolerated and definitely tends to work. In the immunotherapy, that's the rituximab that you're referring to, absolutely good treatment, but that's in combination with two other drugs, as I said, the RFC. But in fact, in more recent times, as I alluded to earlier, there are certainly tablet forms of drugs available. These are the B cell antagonists. The most common one and the first one that was developed is a drug called ibrutinib, and there's another one called idelalisib, and there's newer forms of this ibrutinib, nemtabrutinib, and a few other ones that are now becoming available. So certainly there are other options for CLL.
I'm going to do two more, Doc, and then we can conclude, right?
Absolutely.
So, Jazakallah for the program. A Hakim has recommended, together with blood transfusion, giving my daughter thalassemia major a med called LIV52DS, which is a Himalayan product. I'm scared of it having other negative effects on their health or actually causing more harm than benefit. Any advice, please?
Yes. So the first thing to say is that um, we should not be of the mindset that only so-called in inverted commas, Western medications work. Western medications do not have the monopoly on cure. We said earlier that cure, of course, belongs to the Almighty, certainly, and He can put cure in many different things. Now, with respect to this particular compound, LIV52, I cannot say that I have any knowledge on this particular drug, but I certainly can check this up. I'm not aware of this drug used in thalassemia myself. I have a few thalassemia patients, and perhaps this drug will be something of value. I can look into it. I welcome you to contact me, and I can certainly look into it and perhaps see if there is some truth to the claim.
How do I bring my levels down without a chemical treatment for CLL?
Okay, so the levels that the person is referring to most likely is the levels of the white cell count. So there are other reasons in CL for the white cell count to be high. The primary reason is this malignancy, in which the bone marrow is, of course, producing these malignant cells, and they can become extremely high. The first important thing is once it is staged, to not be fixated on the white cell count. The white cell count is not the be all and end all, because all patients do not require us to lower the white cell count. So in other words, a normal white cell count is around 10 or so. Even CLLs who are early stage disease do not have poor prognostic sign and have a white cell count of 150 or 150,000. This is extremely high, don't necessarily need treatment. Now, how do you bring these levels down without chemical treatment? Well, the chemical treatment you're referring probably is chemotherapy, and that's the agents that we discussed earlier. The only one that I know that is not chemotherapy is, of course, the immunotherapy that one of the earlier questions referred to, and that's the rituximab. So rituximab is not a traditional chemotherapy; it's immunotherapy. It's a targeted therapy. It's targeted at this particular uh, protein or marker on the cell, and hence it works much better and certainly has less side effects. Apart from this, from the drugs that I know of, I don't know of any other way really to get this white cell count down.
Dr. Saab, we say Jazakallah, it was really a very good program. May Allah subhanahu wa ta'ala grant cure to all those that are sick. May Allah reward you all. Inshallah, hopefully this will be beneficial to the listeners this evening, and Allah ta'ala make it easy for one and all, inshallah.
I mean, Jazakallah Maulana, Jazakallah again for the invitation and the wonderful questions. You've given me some food for thought, some of the questioners. Inshallah, I'll be looking into some of these things, and hopefully, I'm certain it will benefit me as well.
Jazakallah khairat, one and all. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullahi wa barakatuh.